Welcome back to the studio. I'm joined beside me on the sofa with Salvatore Benfatto, who you saw a wonderful talk from earlier, and Lennart Kester, who's going to be talking tomorrow. And you saw Gordon's opening speech talking about the increasing power of computational horsepower out there in the technology sector that is driving life sciences and driving scientific research to be able to do more with the data we have and also to move faster. So we're here today to talk about cancer, AI, and the need for speed. So AI is a very overused word. We were discussing this earlier. And first of all, I just wanted to ask, Salvatore, you're a computational biologist, and how do you think we should use the language correctly? Is it machine learning? Is it AI? When is it AI? When is it generative AI? In your experience, what should we be calling what?
Yeah, I think nowadays AI is a very common term. And I think the people in the field still prefer to use machine learning most of the time. Also, I want to point out that all these models we are seeing being used, especially in the diagnostics, are not the one that we are used to hear all the time nowadays, that are more the generative AI. So these are more like traditional machine learning that are trained on data where just we want to predict some labels. So I think, yeah, it's an important conversation to use the right terms for the right type of model we are using. Yeah.
Absolutely. And Lennart, how do you use the terminology within your teams, how you communicate with each other?
So we also use the word AI a lot, but I think, like Salvatore said, it's more we're trying to find a known label to a new sample. So we're not generating new entities. We're just trying to help the diagnostic process by labeling it with the right entity. And that, I think, is more machine learning in the sense of the word, and it really is a generative AI problem that we hear so much about now.
Cool, excellent. Well, it's helping us move faster. So you're working in CNS tumours, Lennart, and you're working in leukemias, Salvatore. Can you help us understand why getting to an answer faster is important for your field and, of course, for the patients?
In the leukemia field, we just started using this kind of approach. So looking at this methylation pattern, so the fingerprints of these tumors, to understand rapidly which type of leukemia the patients are dealing with. And the rapidity is important because the traditional conventional diagnostics right now require days. And we were just listening in the breakouts that this is not also the same in all the countries. So in some places this can require weeks. And we are talking about sometimes these cases of fast-growing tumors that require urgent treatments. So doctors need to know as soon as possible which type of leukemia they're dealing with, because they have different outcomes and treatment options. So speed, it's important, and also as a guidance maybe to further analysis downstream.
Fantastic. Yeah. And in solid tumours?
Yeah, so we have developed model both for CNS, so for central nervous system or brain tumors, and solid tumors. And for brain tumors, the need for speed is in our center very obvious, because brain tumor surgeries can take a long time, but usually you only go in once. So you want to do a resection up front. So there's no definitive diagnosis when the surgeon starts the surgery. And what we're now able to do is give that definitive diagnosis to the surgeon while he's in surgery. So he can actually adapt the surgical strategy based on the results we give him. And that might change the outcome for the patient. So it's a very clear benefit there.
Fantastic. And so obviously you're using AI to do this. Can you both explain to me how the link is between the AI and the rapidity of that decision?
Yeah, so the AI here was essential because with the very short time frame that we have, we're never going to get a full genome coverage. So we only have tiny bits and snippets of information throughout the genome that are not enough for normal algorithms to use to classify a sample. Now with the neural networks that we're using, which is the type of AI we're using, that is okay with not knowing a lot of the information. So it can deal with only knowing about 5% of the genome, and that's still enough data to get a good classification. So that's where the AI is really essential.
Fantastic.
Yeah, I really like to use this analogy. It's like if we are looking for a fingerprint, but we only have some, spots. So we need to have this kind of complex models that are able to understand which type of tumors the sample belong, just looking at tiny little piece of information rather than the global picture. So that's how AI and machine learning models are helping us to do that.
Fantastic. And what's the importance of training sets and making sure that the machine learning, the AI that you're using is getting to the decision-making process that you need to happen?
I would say the reference data are essential because our predictions are as good as the reference data that we provide. So especially in our experience with the leukemia, building a reference cohort was a major step because we need a lot of data to train these models, and this data need to be labeled properly because, as we were saying, we are just doing labeled predictions. So we are not generating any new information. So I think also that is a step that still requires a lot of manual curation, so human intervention. It's probably often forgot that still we need humans in the process to build this data set. They need a lot of quality control, and I think it's still an essential part.
Yeah, interesting. How do you think about training data and, in fact, multimodalities? Are you thinking about richer data, the kind of data that hopefully Oxford Nanopore can help you with?
Yeah, hopefully that is where we'll move in the future. So the thing is that for what we're doing now, we've used thousands and thousands of samples as training. And that is all done still based on Illumina methylation arrays. But those are very limited in what you get in terms of information. But there's very many samples. So ideally, we would like to switch to other methods that get like full genome methylation patterns. But that'll take time to generate all those samples. And that's something that will hopefully come, but for the time being, I think we still rely on the methylation arrays. Yeah.
How about the international data set? So I don't know if you're familiar with the UK Biobank is mapping 50,000 methylomes. These international data sets that are being created, do they feed into your models of methylation, for example, or do you benefit from international data sets to train as well?
Yeah, a lot. So, but this is really depending on collaboration. So there's a lot of. Sometimes it can be difficult to align all the data and to get everybody on board and using the data for a single purpose.
Yeah.
But this, I think, is still something where, as a research community, we can do more to share data and to allow data to be used for other purposes. And there is a lot of good work being done by many centers. So it's really moving in that direction, but it could be even better.
Yeah, fantastic.
Yeah, I agree. Having public available data is essential, especially in academic settings. So all this Illumina array data that are available, so we saw in the brain tumor and now in the leukemia field, because we have access to this data because all these authors made them publicly available.
Yeah, fantastic. Yeah. And so as we think of AI or machine learning as a skill set, how are you thinking about your teams and knowledge base around this? And is there any resistance to using these kind of new analytical techniques in your work?
So I feel very lucky because our team is composed by different expertise from the clinical side, from the nanopore sequencing, and also the computational. And we really teamed up and bringing our own expertise on the table and trying to understand each other and trying to find a common language. And I think that, of course, as for all the technologies, there could be some resistance. It's understandable. We need to provide the evidence that this is working. And so we need to do this in bigger and larger cohorts and still doing in parallel what the conventional diagnostics to convince, and also, I mean, also for ourselves to test these models. That's very important.
And so what does that evidence look like? I think, Lennart, you're doing this over a 2-year program to compare pathology insights versus the AI approach. Is that right?
Yeah, exactly. So we're now starting a study where we'll compare the intraoperative diagnostics based on a frozen section that a pathologist can look at to the classification that the algorithm gives. And then hopefully after this 2-year period, we'll be able to say what is the we'll be able to say what the concordances are and what the disconcordances are. And then especially in the latter, what is more reliable? Is the AI more reliable, or is the pathologist more reliable? And we were very lucky in the sense that our head neurosurgeon was very open to use these new technologies to help him do his surgeries. And I think that is also essential, to have the end users be excited about the technology and wanting to use it. That's the only real way to get it in the clinic.
Well, how would you be thinking about your career? Say you're a pathologist, you're an early career pathologist, AI is springing up all around you. How do you plot your career path through that?
So I think if you're an early day pathologist now, you really need to embrace these new technologies.
Yeah.
Because this is where we're heading, all of us, and we've seen molecular diagnostics become more and more important, and this additional layer of AI gives that even more power. So this will become a bigger and bigger portion of a pathologist's work. So embrace it.
Fantastic.
Yeah, I agree. Yeah, I mean, this should be seen as a guide.
Yeah.
So it's not replacing; it's really helping. Yeah.
I think you were saying that it's a co-pilot, right?
A co-pilot.
Yeah.
Yeah. That's how I think we should see it. Yeah.
Yes, fantastic. Do you see a future? When do you think it will move on from being a co-pilot into something that is, driving its own diagnostic processes? What has to happen from a computational
fully
perspective?
AI powered without any.
When does the pathologist get removed from the decision-making process?
Honestly, I'm not sure if we'll ever get there. If you want to have medical decisions being solely driven by an algorithm, who's responsible if it's wrong, right? Those sort of questions then come into play. So I think there will always be a human interpreting the AI and either agreeing with it or disagreeing. So one of the very simple examples we had in the beginning is that when we started doing this in surgery, we had a lot of classifications that were either wrong or unknown. And that turned out to be because the piece of tumor we got from the surgeon actually didn't contain tumor. And then what we did is we changed our workflow, and is that we got 3 pieces, and the pathologist had a look at all 3, and then told us this is the most representative part of the tumor. This is what you should use for the AI. So that also is an essential part of getting this right. So it's really the collaboration between human and algorithm.
Fantastic. Do you have ethical teams as you go through this, reviewing the approaches?
I think that is something that is now starting to build up, right? Because this is all new, and usually ethics follows technology. So first the technology is there, and then we start thinking about, how do we actually deal with this as society? So that's now coming up. So yeah, we'll deal with that as we move along.
Well, maybe on the tumor panel board, we should be starting to think about these systems around bringing the ethicists into the early conversations, so that we're not surprised by the march of AI moving faster than we can deal with it as a society, right?
Yeah, it's a very fast-moving field.
Yeah, fantastic. Well, it's been absolutely fantastic having a discussion with you here today. I'm going to leave you with one question. Where will we be 1 year from now, do you think?
I think this is, also from what we heard today, this is clear, moving fast. So AI-powered cancer diagnostics is becoming, in the brain tumor field, it's years that it's a reality, and we hope to extend this to other tumor types. But I can see, and I hope that it will be also embraced by a larger community over the next months. Yeah.
Yep. 1 year. What can a year bring?
So I think what we're starting to see is that there's other centers that start adopting the technologies we developed. And I think that's really one of the reasons why we do this, right? So it's great for our own patients, but it would be even better if other centers also start using it, and if we can maybe at some point get a global community that starts using these sort of tools, where there's a few places that develop them, but then a lot of places that can actually use them.
Fantastic. Well, thank you so much for joining me today for this discussion. It's been absolutely fantastic. Good luck for your talk tomorrow. Well done for your talk today. We've also got some other solid tumour researchers also coming to join us on the sofa at the end of the day, so we'll look forward to hearing from them as well. So thank you so much.
Thank you.